Hi everyone, I'm Divya Sebastian. Today I'm going to talk about the abdominal assessment of a patient post hemicolectomy. Patient profile. Mr. G is a 53-year-old fit and active gentleman who was my patient in the intensive care unit post hemicolectomy secondary to bowel perforation. History of presenting compliance. Mr. G presented to ED with sudden onset of severe generalized abdominal pain, 2-day history of nausea and vomiting, diarrhea, and fevers. Moving on to the health history. Past medical history, hypothyroidism, and Crohn's disease. He had been on treatment with mesalamine previously for the Crohn's, but not on any active treatment for the past year. Nil significant surgical history, family history. Father died of myocardial infarction at age 65. Social history. He is a non-smoker and a social drinker, and there's no illicit drug use. Home and work environment. He lives in his own house, which is a loss at home in an acreage property, and he runs a family business. Exercise and diet. Works out regularly in gym, goes out for run, follows a healthy diet, and he avoids dairy products due to the Crohn's disease. Nil non-allergies. Current medications are levothyroxine 100 micrograms daily. Events leading to ICU admission. In ED, Mr. G was hypotensive, febrile, and tachycardic. Blood results showed elevated white cell counts, CRP, and lactate. Raised white cell count and CRP suggest infection and inflammation. High lactate level is a significant indicator of sepsis. CT abdomen and pelvis showed free fluid and air, suggesting all four quadrant peritonitis. Patient's symptoms, presentation, and the diagnostic evaluation suggested sepsis from bowel perforation. Sepsis is a life-threatening medical emergency. Early detection and prompt treatment help save lives. When sepsis is suspected, treatment includes fluid resuscitation, broad-spectrum antibiotics, analgesia, antiemetics, and possibly emergency surgery. Mr. G was treated with 3 liters of IV fluids and triple IV antibiotics in ED and was proceeded to emergency surgery. There was perforation at ileocecal junction and pus-filled peritoneum. Right hemicolectomy with formation of ileostomy was performed laparoscopically. Patient was transferred to intensive care unit post-op as the patient required boluses of metronidazole intraoperatively to support blood pressure. Sepsis is caused by the body's extreme response to infection. This chain of resuscitation focuses on early detection, source control, and prompt treatment. According to this, the first 6 hours of presentation are very critical, and the appropriate management during this time prevents morbidity and mortality. DOT to antibiotic time is one of the most important elements in the management of sepsis. Most of the healthcare systems these days follow a designated sepsis pathway, which helps in the early identification of sepsis and prompt management. Overview of general physical assessment. Mr. G was alert and orientated. Observations. He was hypotensive with a MAP 65, otherwise vital signs were unremarkable. Pain assessment. Pain score was 4 out of 10, so I used a numeric rating scale to assess the pain. This scale can be appropriately used in adults that are alert and attentive, and also in children who understand numbers. It's a scale from 0 to 10, with 0 being in no pain and 10 being the worst possible pain. For assessing the pain, you can use different mnemonics, and I used OLCAT. Onset, the pain onset was gradual since the surgery. L for location, pain all over the abdomen, especially in the left lower quadrant. Duration, lasts almost 10 minutes post any movement. Character, dull ache and a constant discomfort. Alleviating factors, resting, and aggravating factors, movement and coughing. Radiation, nil radiation. Treatment, patient is on intravenous patient control and analgesia. So moving on to the abdominal assessment. Abdominal assessment consists of 4 major techniques: inspection, auscultation, percussion, and palpation. Abdomen is divided into 9 regions and 4 quadrants, as per the picture in the slide. So this is for the ease of clinical examination and communication. Each region or quadrant has its own corresponding organs. Inspection. These are the main elements to be focused while doing inspection of abdomen. So first one is contour. So the patient's contour of the abdomen was slightly rounded. Symmetry, bilaterally symmetrical. Rectus abdominis muscles was intact. Pigmentation and color was uniform color throughout, nil pigmentation, and no dilated abdominal veins. Scars, no old scar marks. So he's got a new small midline incision and 2 port sites on the abdomen, and there's a transparent cum field dressing over the midline, and the port sites are glued. Respiratory movements, symmetrical respiratory movements, so abdomen rises with inspiration and falls with expiration. And no visible masses or nodules, no visible peristalsis, no visible abdominal pulsations. Umbilicus, midline incision extends till the umbilicus, and umbilicus is slightly depressed with no visible umbilical hernia. Next technique is auscultation. Both bowel sounds and vascular sounds are auscultated using a stethoscope. Bowel sounds should be auscultated in all 4 quadrants. In my patient, bowel sounds were hypoactive. Hypoactive bowel sounds indicate decreased bowel motility and can be common post-major abdominal surgery. At the time of assessment, Mr. G was only few hours post-abdominal surgery. Vascular sounds, no bruise heard. Next is percussion. General percussion, tympani in all quadrants, liver span, dullness, spleen unable to assess, stomach, tympani over stomach, bladder was unable to percuss above symphysis pubis as the patient had an indwelling catheter. All these findings were unremarkable. Next one is palpation. Light palpation. The abdomen was smooth and warm to touch. Abdominal muscle guarding. Tenderness and pain was present throughout the abdomen. Deep palpation was not performed due to pain. Assessment of abdominal tubes and drains. Enteral tubes, he had a nasogastric tube which was figured, and 4 hourly aspirates showed clear liquid with no blood stain. Drains, there was 2 Blake's drains sutured to the skin on the left side of the abdomen, and each drainage bag had about 40 to 60 ml of hemoserous fluid, and the surrounding skin looked healthy. Intestinal diversions, ileostomy. So stoma was looking red and the surrounding skin was healthy. 50 ml of liquid brown stool in the ileostomy bag. Urinary diversions, 14 French indwelling catheter, which is draining clear urine, and urine output was 80 to 120 ml per hour with no hematuria. Moving on to the identified nursing priorities for this patient. First one is treating hypertension. The patient was hypertensive with MAP 65. The recommendation by the consultant was to aim for MAP above 70. A total of 1 liter of albumin 4% was given with no significant improvement. So the patient was commenced on noradrenaline infusion to keep MAP above 70. According to research, noradrenaline is the first-line vasopressor recommended if hypertension persists after IV fluid resuscitation. The second priority is treating infection. Infection was treated with IV metronidazole and ceftriaxone. According to recent studies, early administration of broad-spectrum antibiotics is vital when treating suspicious or confirmed cases of sepsis. Any delay in administration of antibiotics is associated with increased mortality rates. In sepsis or septic shock, individualized dosing of empiric antibiotic therapy should be administered within the first hour of diagnosis. The next priority is pain management. The patient was on IV oxycodone PCA. PCA gives patients autonomy and control regarding the amount of analgesia used. Evidence suggests that postoperative analgesia is essential for early recovery and successful patient outcomes. Adequate management of acute postoperative pain improves the patient quality of life, enhances early mobilization, and reduces hospital stay and cost of care. The next one is wound care. All surgical sites is to be inspected for any signs of infection like warmth, redness, swelling, and discharge. Dressings to be changed if the dressings compromise with profuse discharge. The most frequent symptoms of surgical site infections include fever, malaise, fluid drainage, increased wound pain, redness and swelling around the wound, and loss of function and movement. The last one is stoma management and education. Stoma and surrounding skin need to be observed for color, swelling, bleeding, and redness. The patient had an opportunity to see the stoma for the first time while I was changing the stoma bag. Stoma looked red and surrounding skin was healthy. The patient should be taught about taking care of stoma, like changing and emptying the bag and accessing supplies prior to discharge. The patient or carer should be confident enough to take care of this. Stoma can have different complications like bleeding, mucocutaneous separation, stoma separation from skin, peritonitis, stoma retraction, necrosis and prolapse, and bowel obstruction. Stoma surgery can have severe impacts on the patient's daily life for the rest of their lives. There will be changes to bodily function, altered body image, and personal care needs which require adaptation and acceptance. These changes can have a psychosocial impact on patient and their family and can be emotionally challenging. The role of CNCs in stoma care is to provide education about the self-caring of stoma and to provide physical and emotional support for the patient and their family. My references are as follows. Thank you.